We have a West Point Town Hall here focusing on Ebola. The whole objective here really is to get some information out there, dispel some rumors, answer your questions, and just give you the best information that we have available at this time about what's going on. And we're fortunate this morning, though we have the commander for Keller Hospital to be our speaker this morning, going to show a video, answer some questions. So this time I'd like to go ahead and introduce Colonel Burlingame to come and speak to us. Thank you.
Thanks. Appreciate it. I'm Brian Burlingame. I'm the Director of Health Services for West Point, also the Keller Army Community Hospital Commander. I appreciate all of you coming out today. I know Ebola has been in the news, and for some of you it's been a significant issue in your households, an area of concern for some of our first responders that are in the audience today. Our goal today really is to show you some of the basic information that the CDC is putting out, to give you an opportunity to ask questions, to either reinforce facts or dispel myths. So a short video and then questions for you. Many in the audience are supervisors. Hopefully you'll be able to take this back to your staffs and provide correct information. Thanks.
Ebola virus disease, or EVD, is a preventable but often fatal viral disease. As of September 2014, a large EVD outbreak was centered in 4 countries in West Africa: Liberia, Sierra Leone, Guinea, and Nigeria. This outbreak is the largest Ebola outbreak in history and the first in West Africa. EVD poses no substantial risk to the U.S. general population, and as of September 2014, there have been no Ebola cases acquired or transmitted outside of Africa. A few U.S. healthcare workers have contracted EVD while treating patients in West Africa. The United States Centers for Disease Control and Prevention, or CDC, is working with other U.S. government agencies, the World Health Organization, and other domestic and foreign partners in an international response to the outbreak. CDC has activated its Emergency Operations Center to help coordinate technical assistance and control activities with partners. Several teams of public health experts have been deployed to the West African region, and there are plans to send additional public health experts to the affected countries to expand current response activities. But disease control efforts there have been difficult due to the lack of sufficient health care and resources, poor living conditions, misinformation, and local traditions, along with avoidance of healthcare due to mistrust. Ebola virus disease is caused by infection with Ebola virus, which was first discovered in 1976 in what is now the Democratic Republic of the Congo. Outbreaks have appeared occasionally in the years since. The natural source of Ebola viruses remains unknown. However, researchers believe that the virus comes from animals, with bats being the most likely origin. Yet researchers can only make an educated guess that the first patient became sick through contact with an infected animal. After the first human illness from an infected bat or other wild animal, human-to-human spread begins. When EVD occurs in humans, it is commonly spread by direct contact with a sick person's blood or body fluids, or through objects such as needles that have been contaminated with infected body fluids, or through contact with infected animals. In Africa, given how poor the country's suffering outbreaks tend to be, infection in a healthcare setting is common because of a lack of personal protective equipment and the reuse of improper sterilization of contaminated syringes, needles, or other medical equipment. Also in Africa, other common means of Ebola virus spread include preparing the bodies of the dead for funerals or participating in burial rituals that involve handling the body. EVD is preventable, but often fatal to those who become infected. Healthcare workers and family and friends in close contact with Ebola patients are at the highest risk of getting sick because they may come in contact with infected blood or body fluids like vomit or diarrhea. During outbreaks, EVD can spread quickly within healthcare settings where hospital staff is not wearing appropriate protective equipment, such as masks, gowns, and gloves. Proper cleaning and disposal of instruments, such as needles and syringes, is also important. If instruments are not disposable, they must be sterilized before being used again. Without adequate sterilization of the instruments, virus transmission can continue and quickly speed up an outbreak. Only people with EVD symptoms or people who have died from EVD can transmit the disease. Diagnosing EVD in an individual who has been infected for only a few days is difficult because the early symptoms, such as fever, headache, and weakness, are not specific to EVD and are often seen in patients with more commonly occurring diseases, such as malaria or influenza. However, if a person shows early symptoms and there is reason to believe that EVD is possible, the patient should be isolated and public health professionals notified. The patient can then be tested to confirm infection. EVD symptoms include fever, weakness, loss of appetite, vomiting, diarrhea, headache, and stomach pain. Rash, red eyes, and bleeding are only seen in rare cases. EVD does not spread through water, food, insect bites, or by air, but only by coming into direct contact with infected body fluids or contaminated objects. There is no FDA-approved vaccine or specific treatment for EVD. Therefore, it is important to take steps to prevent Ebola. There are actions you can take to protect yourself. If you must travel to an area with known Ebola cases, make sure to practice careful hygiene. Wash your hands with soap and water at every opportunity. Carry and use alcohol-based hand sanitizers when soap and water are not available. Avoid contact with blood and body fluids. Do not handle items that may have come in contact with an infected person's blood or body fluids. Avoid funeral or burial rituals that require handling the body of someone who has died from Ebola. Avoid contact with bats and non-human primates, such as monkeys, or blood, fluids, and raw meat prepared from these animals. Avoid hospitals where Ebola patients are being treated. If you're traveling to an affected area to provide healthcare to Ebola patients, you should receive special training in standard, contact, and droplet infection control precautions and in the use of appropriate personal protective equipment. After your return, monitor your health for 21 days and seek medical care immediately if you develop fever or any other symptoms of Ebola. Tell the healthcare provider about your recent travel and your symptoms before you go in for treatment. Advance notice will help healthcare providers care for you and protect other people in the medical facility. Some patients who sought care soon after symptoms started have survived with only supportive care, such as balancing the patient's fluids and electrolytes and treating for any complicating infections. There are actions you can take to protect yourself if you are traveling to an area where Ebola transmission is occurring. In addition to Ebola-specific precautions, be sure you are adequately protected from more common diseases in the region, such as malaria. See a qualified healthcare provider to ensure you're fully prepared for all potential disease threats. The situation in Africa is rapidly changing and misinformation is abundant on social media and the internet. For accurate and reliable information about EVD, contact the U.S. Army Public Health Command, the U.S. Army Medical Research Institute of Infectious Diseases, the Centers for Disease Control and Prevention, or the World Health Organization. Be informed, be prepared, and stay healthy.
Okay, so a couple of things in the video that have changed. We've obviously had 2 healthcare workers from Houston that contracted the disease while taking care of a patient that had come from Africa. Both of those nurses survived and are doing well. So at this time, any questions? Gotta be one.
I'm Dan Fett. I'm from DPW, and question is similar to AIDS back in the 80s, Ebola. It's not contacted by hand, but whether somebody spits on a subway or something, you get your hands into that and stuff. Is it contractable that way?
So again, you have to be in direct contact with the body fluids. Again, if someone spits in the subway and you come by at a time remote from that, can that contact? Again, the people that are symptomatic have to have contracted the disease either in a country where Ebola is an outbreak or in a healthcare facility. And so the steps that we're taking right now in this country, both for the military that's there now to quarantine, and for the CDC regulations of self-quarantine and checking your temperature twice a day and seeking health care, make that risk very remote. But again, the way that you contract Ebola is in direct contact with fluids from an infected patient who has shown symptoms.
Does the virus die off after coming in contact with air, blood on the ground?
Every virus has a period of time where it can survive outside of its host, and that's variable virus to virus. And so there is a period of time, it's a couple of hours for Ebola. For a specific time, I would check one of these websites.
Sir, just wanted to know, for those civilian personnel going down to that particular area, is the government now going to quarantine them before they come back, and if so, how long?
As of right now, the national policy is for healthcare workers that are going that when you come back, it's to self-quarantine. There are several states that have enacted legislation to mandate quarantine. At least one state, New York, has backed off that. For the DoD personnel that are going forward under United Assistance, which is a program to send DoD soldiers into Africa to stem the disease. The policy as of today is that they will be quarantined for 21 days at a facility, preferably Oconus, and Fort Bliss has been recognized as a place where any of our soldiers coming back with symptoms will be quarantined, and that's Fort Bliss. Oh, okay, we'll get back to you in a second. Follow up.
Once a specimen is collected and it could be infected with the virus. How long does it stay a length of time in that specimen?
I don't have an answer for that, ma'am. Outside of a host in a vial, I don't have that. We'll look it up and get back to you.
Just one more thing. The people who came back, who were civilians down there, and they were flown back, was the payment done through their insurance company, or was it done by the government? Or is that expected if somebody should contract such a thing and survive it? Are they going to send the individual back? Are they going to leave them down there? Has that been thought out, or is anybody going through that whole process at all?
Right. So the question is, who pays if someone comes back? So presently, right now, the folks that within the DoD are coming back through DoD mechanisms. For the civilians that have come back, I believe only one has been flown back via a government air, and that was the initial case of the doctor that came back on a Department of State aircraft. So that's a Department of State question. I don't have that answer if they billed his insurance company or as part of Department of State activities. Department of State not routinely, but on occasion, will fly back a U.S. civilian from a country and foot the bill, and they have a contract with companies in Africa. International SOS is the main one to fly folks. Here's Lieutenant Colonel Kilbrew. He's our preventive medicine specialist. He's also the public health official for West Point. He has an answer to the question on the virus in a tube.
This actually is also an answer for the gentleman asked previously. This is from the CDC. Sir. All right. Thank you. This information here is from the CDC. The Ebola virus disease can live on hard surfaces, which are the doorknobs and countertops, for several hours. However, the virus in body fluids, such as blood, can survive up to several days at room temperature.
Right. So 2 days after a specimen's been obtained, it could live. Most of the samples that are taken are immediately tested. I think in New York it's about an 8-hour turnaround time. For those that get shipped to the CDC or to Fort Bragg, depending upon which lab you're using, that's going to be in a day. Then the specimen is destroyed.
Hi, sir. Now that people know that it's headache, tiredness, nausea, vomiting, those are common symptoms for a lot of problems that people go home for. Somebody in the office could panic and say, hey, he should be reported, he should go to Keller, he should, what is going to be the protocol now that attention's on symptoms that can have a relationship to Ebola or not?
Right. Well, we're in the cold and flu season. Many of the symptoms that you've experienced in your lifetime are some of the same symptoms you see here that are part of the Ebola complex. So what we have now, if you call for an appointment and you say, hey, I'm not feeling well, I need to see my primary care manager, or if you just show up to the emergency room or walk into your clinic that day, you'll be asked a couple of screening questions. And that's not just here at Keller, but most hospitals in the United States. So over the phone, we'll ask the number one question: have you traveled outside the United States to these areas within a certain period of time? Or have you been in contact with someone or cared for someone that has Ebola? Or have you eaten meat of a dead animal that's been uncooked? And again, if you answer yes to any of these questions, we'll ask you to come into a specific area, which will be the emergency room at Keller, if you call Keller Assets. And we'll look at you, we'll put you in a room, we'll put you in the proper PPE, and then we'll test you. If you test positive, then you'll go to one of several centers in the DoD for active duty. There's been 4 named. Fort Bliss is the referral center. That's the primary. If not, we'll send you to one of 8 centers that have been identified in New York. The 2 that we're looking at is Upstate SUNY and Long Island Jewish, though there are 6 other hospitals that we could send you to if you had EBD or we had a high suspicion. So really, it's how you answer those questions and how you screen is what we do with you. If you just have the headache and you've been living in Highland Falls or here in West Point, we're going to treat you with the same level of concern we do at any other time. So we should always use an appropriate level of PPE if you have a cough or you're sneezing or we think that you may be infective for anything like the flu. And that's the standard we'll go down. Does that answer your question, sir?
Good morning. Tony Davis from the barbershop. The only reason I'm asking this is because I know it's on everybody at the barbershops, the back of their mind is there any precautions for the kids when they come back? We're in direct contact with sweaty kids pretty much every day. And when they come home from visiting all over the world, is there any kind of precaution you guys are going to take as far as them coming back onto West Point?
Okay, so the question, as I heard, is from the cadets or from the staff and faculty, what are we doing to protect the work staff from potential exposure? Is that correct? Again, so we're looking at, again, at the Corps of Cadets, you only are infective if you're within a certain period of time between 2 and 21 days after contracting the disease. That's the incubation period that's out there. You're only infective if you are showing symptoms. That symptom complex ranges anywhere from 2 to 8 to 10 days. 8 to 10 days is the normal course of the disease. So right now, of the cadets, no one has been outside of the country to any of these affected areas. None of the staff and faculty have been outside the country in these infected areas in that time frame, nor is anybody on the staff and faculty, to include Keller, have taken care of an Ebola patient or been in these countries in that time frame. Now, we do know that we have soldiers that are going overseas to stem the tide of Ebola. The DoD policy as of today is that they will be quarantined before they're allowed to come back to home station. We have one doctor that is on that mission from Keller. He'll be quarantined for 21 days and then he'll come back. We may have some other soldiers from here that will go. In terms of family members coming in for travel, to my knowledge, there are no travel restrictions at this time from those countries, but I think we've identified the cadets that are from those countries and they're not going back home for the holidays.
What is DOT doing for international domestic flights?
That's a question outside the scope of my knowledge. We can get back to you. I look at the websites. I'm not sure what the Department of Transportation policy is.
You mentioned earlier about testing a patient. How soon, before a patient is systematic, is there a test that they can do to see if they have Ebola before they actually show symptoms?
So when you have the viruses in your blood, you can get tested. The test is only taken when you show symptoms. So I guess saying, can you get a test because you're worried that you have it and you want to check?
No, my concern is instead of quarantining someone for 21 days, if there is a test, a blood test they can do, wouldn't they just do a blood test on them, see that they're free and let them go?
Yeah, that's a good question. That's a policymaker question right now. Can you test blood in someone who is asymptomatic and see if they have the Ebola virus? The answer is yes. The question is there a time when that test would be a false negative? Meaning, all right, you're not showing symptoms, you get the blood test, it says there's no Ebola, but ultimately you develop Ebola. I don't know what the percentage of that is, but that would be a concern. So one of the things no one's asked about, and I'll talk about it while someone's thinking of the next question, is our PPE process. So what I think this Ebola has done is allowed us to have conversations about our habits when it comes to other infectious diseases, right? So we're all worried about Ebola because it's a high lethality. But in this country, we know that at a minimum, we expect anywhere from 3 to 49,000 deaths this year just from the flu. That's a significant number, and it's more deadly than Ebola. So it's made us think about how we handle infection control, not just in our facility, but hopefully in your homes, with good hand washing, covering your mouth and your nose with your arm, or when you cough, making sure you wipe off surfaces if you've coughed or sneezed, and if you shake someone's hand. So we're more mindful of how we spread germs. So that has been part of what we've been doing in the MTF, is going back and making sure, not just for Ebola, but for all of the other infectious diseases, that we're maintaining the appropriate level of precautions. Now, for Ebola specifically, again, depending upon your risk, there's multiple levels of PPE that we would use. The first level is what we'd use for any other infectious disease. If you're someone that we find to be a high-risk patient with these symptoms, we're going to get into the appropriate level PPE here. You see the folks on the video, and you've seen them on TV. They have the yellow Tyvek suit with the green gloves, and folks look at that and say, well, that's what we need at my house, or that's what we need at the hospital. That's for a very specific level of concern. We don't need to have that. There's also, as you would expect, there's only so many folks that make that suit. Really what you want is the specification that suit really confers, which is impermeability. So we have lots of things that don't look like the suits that you see on CNN that are impermeable. And so that's what we would use at the hospital. So if you see our first responders in suits that don't look like the suits on TV, if you see the hospital workers and things, they still have the appropriate level of PPE, not just the brand name. Okay. One of the messages at the end of the video clip is one I want to highlight. It's one I've shared with my staff as medical professionals, and you as supervisors that are supervisors in the audience, I'd ask you to do the same. There's a lot of information out there. That information comes from different news sources, some of which are mainstream news sources, some of which are blogs, some of which are different places. It's a multimedia world today. I would caution you to how much credibility you put in that information. These news sources, many of them now are commercial enterprises. Ratings are important for sponsorship, and even though they have a duty to the public, they also are aware of getting folks on the fringes to discuss certain aspects of Ebola that are not based in science, drive up market share. And they also, frankly, stoke fears. So these 4 websites are the most reputable websites. And when you start making decisions and you start formulating your opinions on Ebola, and many you already have, I challenge you to use what's out there that we know from science. One of the things that was in the news recently this week, and I'll broach that, is, can Ebola become airborne? It was a question that was asked by a Department of Defense agency, because that's their job. Their job is to think about all the gee whiz, what could happen possibilities in threat analysis. It wasn't because they had a legitimate concern of, scientifically, I think this is possible and this is what we're doing. Is it possible? In the last half a century of new viruses that I'm aware of, and we can go back even further than that, not one virus has changed its mode of transmission. Viruses do mutate, viruses do change, and they sometimes will change based on how we attack them. But in terms of their mode of transmission, no virus has ever transferred. So again, Ebola is not airborne at this time. There is no suspicion it will become airborne, and that's a concern that's been out in the news in the last couple of days. Okay. Anything from? I really appreciate your time. And again, as you go back home, talk to your colleagues, formulate your opinions. Oh, okay, go ahead.
Have you developed immunity to it?
Have I developed immunity to it? No. I'm sorry? That's a good question. So as a person, once you get hit with a virus, you begin to develop immunity to it as you fight that virus off. So, but a natural immunity to it, looks like any virus, can it occur? Yes, but that occurs over many, many months or years. The main way to get immunity to a virus is to have the virus and survive. So the other way we get immunity is through vaccinations, right? We all have the flu drive this last couple of weeks. We've got one actually today. So that's an immunity through a vaccination. Right now there is no vaccination that's FDA approved for Ebola. I know that folks are working vaccines from multiple countries, so that would be the next step, and that's to get conferred immunity from a vaccination. I thought somebody had a... Hey, Don.
So, in a lot of ways, we're unique here at West Point, just based on the sheer numbers of foreign visitors that we have to come to visit West Point. So, my question is, taking into consideration the science, because I think once we get away from the science, the fearmongers raise their ugly heads and we can't have any type of conversation. Staying within the science, if we had a visitor that came to West Point and we found out that they were within that time frame of being contagious, how would we deal with the personal contacts that visitor may have had while they were here at West Point?
Yeah, so good question. The first thing we do is we assess that person, right? So that person would, come in. We would do the same things we would do for a beneficiary. We talked about it, ask them the questions, isolate, test, and transfer. If the Ebola came back negative, then the scare is done. If it came back positive, that's a different story, and that's where the harder you're getting at. I think at that point, we would let the community know that there was a person on West Point that had Ebola. We would try to identify, if we could, to the best degree, what subset of people were at the greatest risk and in contact. Again, you have to be in, if he was just walking by, or there was some spit on the street, this doesn't aerosolize. You'd have to literally reach down, and swallow that spit, right? You're not gonna, I'm pretty sure we don't do that. And so you're not going to catch it just from casual contact. Even if the person is symptomatic, it has to be direct, close contact. And I would use an example to kind of illustrate. Let's look at our first case in the United States in Houston. Lots of people, to include his family, were in contact with him, didn't catch the disease. Lots of folks in the emergency room were in contact with him, didn't catch the disease. Lots of folks on mass transit didn't catch the disease. It was only the folks that were in direct, close contact with him when he was very, very sick in the ICU that caught the disease. And it's unclear why, but the assumption is because the PPE was at some point had broken down. And so again, you'd have to say the risk is still pretty low. Understand the risk is there, but we would inform. Try to find out, is there a subset of folks that are at high risk? If we can identify them, we'd bring them in, see how they were doing. If not, as folks would come in, we would alert them, if you have these symptoms, please come in, and then the ability of self-quarantine. I know that for those that are coming in, it goes back to the initial question on self-quarantine. Most states have allowed that if you self-quarantine, they'll cover your expenses. So they'll cover your job pay while you're on quarantine. So I heard that question. So that's why they asked the question. Do I think that? I don't have that knowledge base, but I think the smart people are asking that question. Just like any biologic. It's probably not, based on its properties and what I do know about weaponization, it's not one that would probably do well, but the people from Defense Threat Agency are asking that question.
What was the question?
Can you use that as a weapon? So I almost hesitate to address that because it is a fair issue, but it's again, it's a biologic, and like any other biologic, it's out there. and you can look at how many biologics have we used in the last 10 or 20 years, and folks have been looking to do that.
The question was, would it be eliminated?
Oh, I thought he said it would be weaponized. Okay, that's why I didn't hear you. Could it be eliminated? Sure. I mean, through good public health practices, we have a history of viruses being eliminated, right? And sometimes that also is part of immunization. Immunizations have done that. They wiped out certain diseases in this country for a century. We see some of those diseases come back as folks have stopped immunizing based on some concerns for immunizations. But just good public health practice has, frankly, wiped out Ebola in certain areas. There's been no Ebola in Nigeria now since mid to late September. September 19th, I believe, was the last day we had a case in Nigeria. So it's already done in Nigeria. Okay. All right, thank you everyone for your time. I really appreciate it. Good afternoon. I'm Colonel Burlingame, the Health Services Director for West Point. I want to thank those of you that are able to come to our morning town hall on Ebola preparedness. For those of you that are watching on the command channel, I appreciate you tuning in to gain information on this critical health issue. After the event, we realized that there were a couple questions that many folks had asked that did not get answered, or certainly on your minds. So we have brought Mr. Lanier, who is our PAO, to ask some of those questions. So this is a play on one of the questions that was asked during the question and answer discussion period of this morning's brief. And it had to do is, can you develop immunities to Ebola? And the answer really focused on immunizations. But of course, as we see in Africa and even in the United States, some people are exposed to people with Ebola, but they're not getting sick. And that has to do with the normal, healthy immune response that we all have. Think about the folks you come in contact with in your families or in your workplace that have a cold or that are sick. Your body has a natural immunity to bacteria and the viruses, and the healthier you are, the easier it is to fight off these diseases. The sicker you are or the less healthy you are, the easier it is to succumb to these diseases. So there is a natural immunity to all diseases, but disease-specific immunity, which the question was about, talked about immunizations and possible treatments for Ebola. So this question is about risk. This question has been asked several times by folks this morning. Concerned, can they get Ebola from the subway, from a keyboard at work? We know what the transmission mode of Ebola is. It's in direct contact with ill patients toward the end of the disease through body fluids, whether it's blood, vomit, diarrhea, and other body fluids. So those are the risk points. Ebola can last on a surface up to several hours. And again, you have to have had travel to Africa or been exposed to a patient who is sick with Ebola to transmit the disease. About a month ago, the superintendent, Lieutenant General Caslin, asked the garrison and Keller to come together and develop an Ebola response plan. Fortunately, the Army had already developed or was in the process of developing preparedness plans for Ebola. Several months prior, the DoD had decided to undertake Operation United Assistance, placing DoD soldiers and civilians into Africa to stem the tide of the Ebola outbreak. Part of that plan was to take care of the soldiers and their families upon return from the mission. Now, the two healthcare workers that were rendered ill in Houston from the Ebola virus shifted that plan to the left. So we're working in a planning cycle that was much tighter. During that time frame, we followed the MedCom and INCOM operations order, followed the CDC guidelines, and put those that training out to our staff. Over the last several weeks, we've had multiple exercises to include patient flow, as well as donning and doffing of PPE, which is personal protective equipment, which is one of the issues that was found in the AAR from both the Emory patient and the patient in Houston. Over the next several weeks, we'll have multiple opportunities to exercise our plans. Specifically, tomorrow we have a post-wide exercise that involves both the Garrison's BLS system through the fire department and Keller Community Hospital. We have a mock patient at one of the housing areas that will call the system. He will discuss his symptoms and his travel history that will prompt EMS to recognize as a high-risk patient. They will respond appropriately in the PPE. They will protect the patient, sequester the patient, and bring him to Keller. At Keller, he'll be brought through the emergency room and be treated as a patient with a high likelihood of Ebola, and our process will go from there.